non-federal hospitals were the third highest among all classes of pharmaceutical agents in 2009, and overall, antibiotics are reported to be the second most frequently prescribed class of pharmaceuticals. Approximately 40% of hospitalized patients receive an antibiotic during their inpatient stay. In 2010, in the outpatient setting, an average of 0.8, that is almost 1, antibiotic prescriptions were written for each person in the U.S. One would think that we are all constantly suffering from bacterial infections. If this were true, one may wonder how the human race failed to become extinct before the availability of antibiotics. In fact, however, as much as 1/2 of antibiotic use is inappropriately prescribed. There are a number of reasons that an antibacterial prescription may be considered inappropriate. These include the absence of a bacterial infection or indication for prophylaxis, or a violation of one of or more of the following Ds of optimal antimicrobial therapy. That is, the right drug, the right dose, the best route of delivery, attention to de-escalation, and the appropriate duration of administration. Inappropriate use is associated with poor patient outcomes, including adverse drug reactions, organ toxicity, superinfection, for instance due to Clostridium difficile, selection of antibiotic resistance, and in critical care patients, increased mortality. It also results in excess costs, not only drug acquisition costs, but costs accruing from the management of complications, prolonged hospital stays, and costs associated with the emergence of antibiotic resistance. The emergence of resistance is increasingly problematic since the development of novel, effective antibiotics is almost ground to a halt. Antibiotics are a precious resource. Antimicrobial stewardship represents an optimized approach to improve patient care and a sustainable antibiotic future. In a joint statement, the Infectious Diseases Society of America, the Society for Healthcare Epidemiology of America, and the Pediatric Infectious Diseases Society described antimicrobial stewardship in this way. Antimicrobial stewardship refers to coordinated interventions designed to improve and measure the appropriate use of antimicrobial agents by promoting the selection of the optimal antibiotic drug regimens, including dosing, duration of therapy, and route of administration. The major objectives of antimicrobial stewardship are to achieve best clinical outcomes related to antimicrobial use while minimizing toxicity and other adverse events, thereby limiting the selective pressure on bacterial populations that drives the emergence of antimicrobial resistant strains. Antimicrobial stewardship may also reduce excessive costs attributable to suboptimal antimicrobial use. Empiric evidence indicates that antimicrobial stewardship programs are, in fact, associated with a significant optimization of antibiotic use, a reduction in the incidence of infection with antibiotic-resistant pathogens, reduced hospital length of stay, and reduced drug acquisition costs. The tactics utilized by antimicrobial stewardship programs commonly include the following: clinician education, formulary optimization, antibiotic use restrictions, prospective audit with intervention and feedback, optimization of dosing and administration, streamlining, that is, for instance, de-escalation and elimination of redundant combination therapy, early switch from intravenous to oral route of administration, appropriate duration of antibiotic therapy, and implementation of site-specific treatment pathways based on clinical guidelines. Effective implementation of these and other strategies necessarily involves a collaborative effort between colleagues with special knowledge of infectious diseases, pharmacy, infection control and prevention, clinical microbiology, information technology, and healthcare administration. The strategies themselves must be based on the clinical science underlying the principles of appropriate antibiotic use. These principles are, in turn, based on knowledge of mechanisms of action and of resistance to antibiotics, their pharmacodynamics and pharmacokinetics, and potential for adverse effects, including collateral damage. And finally, the available clinical trial evidence demonstrating therapeutic benefit. Antibiotics represent a miracle of science that has saved innumerable lives. The use of antibiotics is, however, a two-edged sword. Antibiotics may also do harm, and also, by their very nature, their use carries the elements of their own inevitable obsolescence. In December 1940, Albert Alexander, a 43-year-old Oxfordshire constable, developed a severe facial infection after having scratched his face while pruning rose bushes. This led to a severe facial infection and to his hospitalization at the Radcliffe Infirmary in Oxford. The infection progressed despite administration of sulfapyridine until, on February 12, 1941, he became the first patient to receive parenteral penicillin for treatment of an infection. On that date, he was given, under the supervision of 30-year-old Dr. Charles Fletcher, 160 milligrams intravenously, followed by 100 milligrams every 3 hours. He had observable improvement after having received a total of only 800 milligrams over the first 24 hours. Alexander had been chosen after a not thoroughly encouraging experience in a single patient in a single-dose Phase 1 trial. As Fletcher told the story in 1984, Florey explained that although penicillin had been found to be entirely harmless to leukocytes, tissue cultures, and a wide variety of laboratory animals, he did not want to risk giving the first injection to a healthy volunteer in case of some unique adverse reaction in man. So he asked me to find a patient with some inevitably fatal disorder who might be willing to help. There were no ethical committees in those days that had to be consulted, so I looked around the wards and found a pleasant 50-year-old woman with disseminated breast cancer who had not long to live. I explained to her that I wanted to try a new medicine that could be of value to many people and asked if she would agree to a test injection of it. This she readily did. An injection of 100 milligrams was administered via an antecubital vein on January 17, 1941, and was followed several hours later by a rigor and fever. This experience resulted in further purification of the preparation with removal of pyrogens before its next administration to a human. While Albert Alexander had demonstrated continued dramatic improvement with continued penicillin administration, after 5 days and approximately 4.4 grams of treatment, however, the entire supply of available penicillin had been exhausted. The limited supply was the result of the difficulties in production, which was originally done in covered bedpans, but these became unobtainable in England during the war. They were supplanted by 700 flat-bottomed stackable ceramic vessels tended around the clock by penicillin girls. But the production problem remained. The exhaustion of the penicillin supply for Constable Alexander occurred, in fact, despite readministration to him of penicillin recovered from his urine, which Fletcher transported by bicycle to the Dunn laboratory each morning. The infection resumed its inexorable progression. Constable Alexander died on the Ides of March, 1941. Once the problem of mass production was eventually solved, penicillin use became widespread. and his December 11, 1945 Nobel lecturer, Alexander Fleming, warned of the danger of bacteria becoming resistant to penicillin as the result of its misuse. In fact, antibiotic resistance occurs with or without misuse as a result of the selective pressure exerted on the bacterial ecology by its administration. The emergence of resistance may be rapid or slow, but it does appear to be inevitable. Among the infections for which penicillin proved to be life-saving was pneumonia caused by Streptococcus pneumoniae. The emergence of resistance to this organism to penicillin was relatively slow to appear. Thus, it was not until 1967, after 2 decades of penicillin use, that investigators reported the first clinical pneumococcal isolate resistant to this antibiotic. The resistant isolate was recovered from a patient with hypogammaglobulinemia and chronic bronchiectasis, multiple courses of antibiotics over her 25 years. While there were only sporadic reports of resistance over the next decade, the emergence of multiple cases in South Africa and other locations of penicillin-resistant, and in some cases multi-drug-resistant, pneumococcal disease was a harbinger of the global diminishing efficacy of penicillin in the treatment of infection due to this pathogen. Staphylococcus aureus took a different path. Penicillin resistance emerged in the 1940s and became pandemic in hospitals in the early 1950s. Currently, 90% of both hospital and community strains are penicillin resistant. The introduction of the semi-synthetic penicillin methicillin was followed within a year by evidence of resistance, which is now pandemic in both hospitals and the community. Penicillin resistance in Neisseria gonorrhoeae can result from a variety of mechanisms, including mutational and by horizontal gene transmission. In each of the above instances, the widespread use of antibiotics exerted the selective pressure that led to the emergence of resistance. In each, horizontal gene transfer played a critical role. Penicillin resistance in the pneumococcus is the consequence of acquisition of genetic material from commensal alpha hemolytic streptococci, resulting in mosaicism in the gene encoding a penicillin-binding protein, the enzyme target of the antibiotic. Gradual accumulation of changes in the gene is associated with progressively increased amounts of penicillin required to inhibit the organism. In contrast, in Staphylococcus aureus, penicillin resistance is due to the acquisition of a plasmid containing a complete gene encoding a penicillinase, an all-or-nothing phenomenon. Resistance to methicillin, similarly, is the result of the horizontal acquisition of a gene cassette. These explain the slow, gradual appearance of penicillin resistance in Streptococcus pneumoniae and its rapid, abrupt acquisition in Staphylococcus aureus. In contrast to these examples of horizontal acquisition of resistance genes, resistance may also occur by additional mechanisms, including upregulation of efflux genes and genetic mutations within the target organism. A remarkable example of the latter was the result of the selective pressure exerted at one institution, high-level resistance to ciprofloxacin in Staph aureus, resulting from chromosomal mutations, increased from 0 to 79% in the first year after its use. These mechanisms described also enhance the possibility of multi-drug resistance. Mechanisms such as these, driven by the selective pressure exerted by antibiotic use, have led to the widespread emergence of resistance in a broad variety of organisms. In addition to the examples just discussed, we are dealing with vancomycin-resistant Enterococcus, extended-spectrum beta-lactamase-producing Enterobacteriaceae, carbapenemase-producing Klebsiella, multi-drug-resistant Acinetobacter and Pseudomonas, as well as others. Antifungal and antiviral resistance is also becoming more prevalent. Clinicians are thus caught between Scylla and Charybdis. On the one hand, withholding antibiotics when they are truly indicated may lead to the death of an individual, while promiscuous use of antibiotics accelerates their path to irrelevance because of the emergence of resistance. Every antibiotic use has a potential public health consequence. The goals of antimicrobial stewardship are the optimization of patient outcomes while limiting adverse effects on the bacterial ecology. In this course, we will present a comprehensive approach to optimal antimicrobial use. While there is general agreement regarding the principles of antimicrobial therapy, the implementation of these principles is often difficult in practice. Nonetheless, they provide a basis that allow for the clinician to optimize outcomes in patients suffering from infectious diseases. In general, the use of antimicrobials can be considered either prophylactic, preemptive, empiric, or definitive. Antibiotics are used prophylactically to prevent infection, preemptively to abort infection, empirically to provide initial control of infection in the absence of knowledge of its etiology, and definitively to cure infection of known etiology. Examples of prophylactic antibiotic use in the outpatient setting include the prevention of endocarditis in selected patients undergoing high-risk dental procedures. In the inpatient setting, antibiotic prophylaxis to prevent postoperative surgical infections is another important example. Perhaps the commonest use of preemptive therapy occurs in immunosuppressed transplant recipients to prevent the development of end organ infection in patients with cytomegalovirus circulating in their blood. Although preemptive therapy is sometimes practiced in the realm of fungal infections, there are no good examples in dealing with bacterial infections. In the outpatient setting, common uses of empiric therapy, including in dealing with patients with acute sinusitis, community-acquired pneumonia, and cystitis. In the first two of these, the clinician seldom knows the precise etiology of the infection, including whether it is actually caused by bacteria. Antibiotic administration is empiric in the initial management of urinary tract infections, but may require alteration depending on the results of urine culture and susceptibility, at which time definitive therapy may be administered. In the inpatient setting, the use of empiric antibiotic therapy is widespread and includes patients with community and hospital-acquired pneumonia, fever with neutropenia, undifferentiated sepsis, and others. Finally, definitive or targeted antibiotic therapy is tailored to treat infection in which the etiologic pathogen and its antimicrobial susceptibility pattern are known. We will now focus on empiric therapy, more specifically on empiric therapy in sepsis. The importance of the choice of an appropriate empiric antibiotic regimen in patients with severe infection is evidenced by the fact that inappropriate therapy, defined as the absence of an administered antibiotic to which the subsequently identified pathogen is susceptible, is associated with increased mortality. Furthermore, the antibiotic must be administered as rapidly as possible, preferably within 1 hour. In patients with septic shock, there is an almost 8% increase in mortality for every hour in delay in initiation of appropriate antibiotic therapy beyond that first hour. Other important elements in the choice of antibiotics for empiric use include the site of infection and the likelihood of antibiotic resistance. Furthermore, identifying the presumptive site of infection provides clues regarding the likely pathogens and may also allow for the possibility of source control, such as drainage of an abscess or removal of a central venous access device. Clearly, the likely pathogens in each case are different. In suspected urosepsis, they are likely to be gram-negative rods, whereas in pneumonia, other pathogens are likely. The clinician should also assess the likelihood that the pathogen causing the infection is resistant to many commonly used antibiotics. Elements which might lead one to that suspicion include a history of recent antibiotic exposure, known colonization with antibiotic-resistant pathogens, frequent exposure to healthcare facilities, and knowledge of local antibiotic resistance patterns. Also to be taken into account are host factors. Some of these, for instance, might preclude the use of individual antibiotics. For example, the presence of life-threatening allergies to a particular antibiotic or class of antibiotics. Also, factors that might steer one away from certain antibiotics may include an increased risk of related toxicity. Examples include the use of nephrotoxic agents such as aminoglycosides or amphotericin in patients who already have marginal or unstable renal function, and especially if they are receiving other nephrotoxic drugs. Of critical importance in the decision-making process is an assessment of the severity and trajectory of illness. How sick is the patient, and how rapidly are they likely to deteriorate? What, in fact, is the margin for error? If I give the wrong antibiotics today, will the patient still be alive tomorrow? This sort of assessment dictates a lot of the kind of decisions that are made in the management of the patient. Other recommendations include ignoring colonization and only treating infection, obtaining cultures before the initiation of antibiotic therapy without causing inordinate delay in the institution of antibiotic administration, and others. Having initiated empiric therapy, the clinician's job is nowhere near completed. The choice of therapy should continually be reevaluated. This approach is supported by a variety of published recommendations. Thus, the Surviving Sepsis Campaign recommendations state that in patients with septic shock or severe sepsis without shock, the administration of effective intravenous antimicrobials within the first hour of recognition should be a goal of therapy. But they also state that the antimicrobial regimen should be reassessed daily for potential de-escalation to prevent the development of resistance, to reduce toxicity, and to reduce costs. De-escalation, however, is not the only decision that might be made. In fact, for example, therapeutic escalation may be warranted in some cases. An important reassessment checkpoint generally arises at 48 to 72 hours, at which time much microbiological information is available, as is clinical information indicating the evolution of the patient's clinical status. At this point, a formal antibiotic timeout should be taken and documented. The decisions during the timeout must take into account the information mentioned above in the context of the bug, the drug, and the host. If a pathogen is identified and its antimicrobial susceptibility pattern has been determined or is highly suspected, an adjustment in antibiotic choice may be indicated, as in the case of a bug-drug mismatch. If cultures are negative, decision-making is often more complex and must be made on assessment of the patient's clinical status and trajectory. There are three general possibilities with regard to clinical status. There could have been no improvement. The patient could be improved, or in fact, the patient's clinical status may have worsened. Let's take the case in which the patient is improving. In this instance, the clinician may either continue the therapy, modify it, or in fact discontinue it depending on clinical status and other available information such as serum procalcitonin measurements. If a pathogen has been identified, any bug-drug mismatch present should be resolved despite the improvement, redundancies in coverage addressed, and antibiotic spectrum narrowed. Adverse effects of antibiotic use dealt with, dosing issues examined, and anticipated duration of therapy addressed. Dosing should be optimized, and consideration given to IV to oral conversion may be anticipated. The issue of the appropriate duration of antimicrobial therapy is sometimes unclear, but in some instances, at least, national guidelines provide clear recommendation. Thus, it is recommended that hospital-acquired pneumonia be treated for only 7 days. Recent data suggests that in cases in which daily ventilatory settings are minimal, that is, a PEEP of 5 millimeters of mercury or less and an FiO2 of 0.4 or less, antibiotics may be discontinued after 3 days. An 80% decrease in serum procalcitonin or reaching a normal value may also allow early discontinuation of antibiotic therapy. The clinical pulmonary infection score has also been used to discontinue antibiotics at 3 days, but its usefulness has recently been questioned. Decision-making regarding starting and stopping antibiotic therapy is more often than not fraught with ambiguity because of inadequate data. As William Osler said, medicine is a science of uncertainty and an art of probability. We can nonetheless optimize our approach by utilizing the principles of antibiotic therapy.
This module is on the principles of antibacterial pharmacokinetics and pharmacodynamics, Part 1. The goal of antimicrobial therapy is the effective and safe treatment of patients suffering from infections. This involves careful consideration of 3 elements: the bug, the drug, and the host. Also of importance is the consideration of the fact that the effect of antibiotic administration extends beyond the individual patient and the target pathogen, and that antibiotics affect the general bacterial ecology of the patient and the patient's environment. It must be recognized that there are 10 times as many bacterial cells as there are human cells in and on the patient, and that this entire varied and massive bacterial burden is exposed to the administered antibiotic, not just the target pathogen. An important consideration is that different antimicrobial classes affect organisms differently, which is why dose optimization of antimicrobials is an essential component of antimicrobial stewardship. The clinician must take into account host and pathogen factors in choosing an appropriate antibiotic, its dose, and its route and duration of administration. Critical to this decision-making process is a firm understanding of antibiotic pharmacokinetics and pharmacodynamics, also known as PKPD. The pharmacokinetics of an antibiotic describes its disposition within the body, including its absorption, distribution, metabolism, and elimination, whereas antibiotic pharmacodynamics examines the relationship between measured drug concentrations in serum, tissues, and body fluid and its antimicrobial effect on the target organism. Simply put, pharmacokinetics is what the body does to the drug, and pharmacodynamics is what the drug does to the body, or in our case, what the antibiotic does to the target organism. Knowledge of these 2 characteristics is important for the selection of breakpoints for interpretation of in vitro susceptibility testing results, as well as optimal antibiotic selection together with the most effective dosing regimen. When an antibiotic is administered to a patient, the pharmacokinetics describes the relationship between an antibiotic dosage regimen and concentration in serum at the infection site. Pharmacokinetics, however, does not correlate the concentration of antibiotic at the site with the antibiotic's effect. Pharmacodynamics, on the other hand, describes the relationship between antibiotic concentration at the site of infection and its biologic effect on the organism. This effect could be bacterial killing or inhibition of growth. Most drugs are reversibly bound to serum proteins such as albumin and alpha-acid glycoproteins. The extent of protein binding varies considerably between different drugs. For example, only 10 to 30% of total serum concentration of gentamicin is bound to serum protein, compared with 90 to 95% of ertapenem. Serum protein binding is an important consideration because, 1, only unbound drug is thought to exert an antibacterial effect. 2, only unbound drug diffuses into extravascular sites. And 3, protein binding may slow the rate of drug elimination, increasing the half-life and thus allowing a longer dosing interval. The most commonly used pharmacodynamic measure of in vitro antimicrobial activity against pathogens is the minimum inhibitory concentration, also known as MIC, and minimum bactericidal concentration, also known as MBC. The MIC describes the lowest concentration of an antibiotic capable of inhibiting the visible growth of an organism in vitro, while MBC is the lowest concentration of an antibiotic to achieve 99.9% bacterial kill. Although MIC and MBC are excellent predictors of the potency of antimicrobial agent against the infecting organism, it suffers from the static nature of the methods used for its determination. MICs and MBCs do not take into account the time course of antimicrobial activity, nor does it mimic physiologic conditions such as the intermittent administration of an antibiotic to a patient, which results in the target pathogen being subjected to a constantly changing concentration of the drug. The MIC also does not provide information on the effects of the antibiotic at concentrations below the MIC, also known as the sub-MIC effect, as well as the post-antibiotic effect, which is the persistent inhibition of bacterial replication after removal of the antibiotic from the system. In vitro pharmacodynamic modeling systems allow continuous adjustment of antibiotic concentration over time in order to mimic human pharmacokinetics. This approach allows the determination of antibiotic exposure thresholds associated with optimal bacterial inhibition or killing. These may also be determined using animal models of infection, such as the rodent thigh model, with endpoints that include measurements of colony-forming units at the site of infection. The most direct and clinically relevant determination of optimal pharmacodynamics is derived from the study of infected patients, linking antibiotic exposure to microbiologic and clinical outcomes. Such data is unfortunately seldom available. The knowledge of a pathogen's MIC against a certain antibiotic, the antibiotic's pharmacokinetics, the clinical status of the patient, as well as data on intersubject variability is necessary to prevent treatment failures. The consideration of all of these factors and the probability of attaining successful therapeutic outcomes based on the drug pharmacokinetics and pharmacodynamics can be estimated using Monte Carlo simulations. Monte Carlo simulations use advanced mathematical modeling to apply the principles of antimicrobial PK/PD to clinical practice. If a group of patients are given an antibiotic, it is expected that there will be a variability in drug concentration time profiles between patients. The peak drug concentration and the time for drug clearance will vary among individuals. Monte Carlo simulations incorporates the variability in pharmacokinetics among a sample population when predicting antibiotic exposure, then calculates the probability for obtaining a target exposure for a range of MICs that an organism can have to a particular antibiotic regimen. An example would be determining the probability of achieving free drug concentration over 50% of the dosing interval for piperacillin tazobactam against Pseudomonas aeruginosa with an MIC of 8. A commonly used measurement is Cmax, which is the maximum drug peak concentration, and Cmin, the trough, i.e. the lowest antibiotic concentration. By using MIC as a measure of potency of drug-organism interactions, the pharmacokinetic parameter determining efficacy can be converted to PK/PD indices. Since only the fraction of antibiotic not bound to serum protein is considered active, these ratios are expressed as the free fraction over the MIC. The three most common PK/PD indices used to predict drug response are 1. Ratio of maximum free drug concentration to the MIC. 2. The duration of time where free drug concentration remains above the MIC. And 3. MIC ratio of free area under the concentration time curve to the MIC. Understanding these three PK/PD parameters, which quantify the activity of an antibiotic, allows us to optimize antimicrobial treatment regimens. The next module will review PK/PD of different classes of antibiotics and dosing strategies developed to optimize efficacy as well as minimizing toxicity. In this next module, we will review specific antibiotics and their pharmacokinetic and pharmacodynamic parameters and how these parameters influences the way pathogens respond to certain regimens and the various dosing methods developed to optimize the antimicrobial activity of an antibiotic. The three most common PK/PD indices used to predict drug response are 1. Ratio of maximum free drug concentration to MIC. 2. The duration of time where free drug concentration remains above the MIC. And 3. MIC ratio of free area under the concentration time curve to the MIC. For concentration-dependent antibiotics, the goal of this pattern of activity is to maximize the concentration and obtain the highest possible antimicrobial concentration at the site of infection because higher drug concentration results in a greater rate and extent of microbial killing. The major pharmacodynamic parameter that correlates with clinical and bacteriologic efficacy of these drugs is peak drug concentration to MIC ratio. Antimicrobial classes that exhibit this pattern of antimicrobial activity include aminoglycosides, fluoroquinolones, daptomycin, and metronidazole. Aminoglycosides are a class of antibiotic that display concentration-dependent killing. High peak aminoglycoside concentrations to MIC ratios are correlated with clinical response. Parental aminoglycosides, particularly gentamicin, tobramycin, and amikacin, have long been used empirically for the treatment of febrile neutropenia or patients with life-threatening nosocomial infections. Aminoglycosides are commonly utilized with cell wall active agents for synergistic activity for gram-positive infections. For the treatment of gram-negative infections, there are two methods of aminoglycoside dosing. The older of the two approach is to administer multiple doses, usually 1.7 to 2 mg per kg every 8 hours for gentamicin and tobramycin. It has long been recognized that ototoxicity and nephrotoxicity are potential complications of aminoglycoside therapy. Application of pharmacodynamic principles may be another method to reduce ototoxicity of aminoglycosides. Recent data have suggested that toxicity is related to drug accumulation within the air and not peak concentrations. When considering the pharmacodynamic profile of aminoglycosides, there are distinct advantages of using high-dose extended interval. First, giving aminoglycosides as a single dose as opposed to conventional strategies provide the opportunity to maximize the peak concentration to MIC ratio, resulting in bactericidal activity. Second, high-dose extended interval dosing minimizes drug accumulation within the inner air and kidney and therefore minimizes the potential for toxicity. Also of consideration is the post-antibiotic effect, which allows for longer periods of bacterial suppression during the dosing interval. And finally, dosing aminoglycosides with high-dose extended interval may prevent the development of bacterial resistance. The Harford nomogram is a commonly used high-dose extended interval dosing method for aminoglycosides. This method aims at optimizing the peak to MIC ratio by administering a dose of 7 mg per kg of either gentamicin or tobramycin. Based on renal function, the dose requires modification in order to minimize drug accumulation. Due to the high peak concentrations obtained and the drug-free period at the end of each dosing interval, this nomogram eliminated the need to draw standard peaks and trough levels. Rather, a single random blood sample is obtained between 6 to 14 hours after the administration of the aminoglycoside. The serum concentration obtained is then plotted on the nomogram to determine the appropriate dosing interval. Fluoroquinolones are another class of antibiotics that display concentration-dependent activity. The PK/PD parameter for fluoroquinolones is the 24-hour AUC to MIC ratio. An AUC to MIC ratio of greater than 125 correlates with optimal clinical and microbiologic outcomes in seriously ill patients infected with enteric gram-negative pathogens. The fluoroquinolone goal AUC to MIC ratio can vary depending on the target organism. For respiratory tract infections involving Streptococcus pneumoniae, the free drug 24-hour AUC to MIC ratio associated with high probability of bacterial eradication is around 30, which is significantly lower than the goal AUC to MIC involving gram-negative microorganisms. The second pattern of killing is characterized by time-dependent killing, which refers to the time it takes for a pathogen to be killed by exposure to an antimicrobial agent. The goal of time-dependent killing is to optimize the duration of exposure. This pattern is most